The following podcast is part of a certified educational activity titled Nurturing Lasting Benefits of Adjuvant CDK4/6 Inhibitor Therapy in High-Risk HR-Positive HER2-Negative Early Breast Cancer. Best Practices for Patient Education, AE Monitoring and Management, and Enhanced Adherence/Persistence. Access the entire activity and complete the post-test at peerview.com/DTQ860. Downloadable slides and practice aids are also available.
Hi there, I'm Erica Mayer, breast cancer medical oncology from Dana-Farber Cancer Institute in Boston. And today we're going to be talking about nurturing lasting benefits of adjuvant CDK4/6 inhibitor therapy in high-risk hormone receptor-positive HER2-negative early breast cancer, best practices for patient education, adverse event monitoring and management, and enhancing adherence and persistence to therapy. So let's jump in. So our goals for today, first, to improve your skills with optimal patient monitoring, adverse event management, and adherence and persistence as part of care plans for patients with high-risk hormone receptor-positive HER2-negative early breast cancer undergoing treatment with an adjuvant CDK4/6 inhibitor. Also, to equip you with strategies for improved education and support of patients with high-risk ER-positive HER2-negative early breast cancer undergoing treatment with adjuvant CDK4/6 inhibitor and endocrine therapy. So let's start with a case. So your patient is named Tina. She is a 58-year-old postmenopausal woman. She undergoes screening mammography that demonstrates a mass in the left breast. Diagnostic mammogram and ultrasound show a 3-centimeter mass, and there's enlarged suspicious axillary lymph nodes. She has a breast biopsy that shows invasive ductal carcinoma grade 3, ER positive 95%, PR positive 25%, and HER2 negative. An axillary lymph node biopsy is positive for cancer involvement. So she is clinically node positive. Systemic staging shows no evidence of distant metastatic disease. Germline genetic testing is negative. So she has upfront surgery. She has a left mastectomy and axillary lymph node dissection. Pathology shows a 2.5 centimeter tumor, grade 3 invasive ductal carcinoma, so T2 size disease, and she has 1 of 3 axillary lymph nodes involved, so she is pathologically node positive. Oncotype score is sent on the surgical tissue, and this returns with a score of 28. So we would consider this high-risk node positive disease. She has completed surgery, she gets radiation, she gets chemotherapy, she begins adjuvant endocrine therapy, and you offer her adjuvant CDK4/6 inhibitor with abemaciclib. So she gets started on that at a standard dose of 150 milligrams twice a day. So I want you to think about that case, and we're going to just talk a little bit about side effects and toxicity, and then we're going to come back to the case. So when we think about CDK4/6 inhibitors, we have to think about the adverse event profile of the agents because there is a distinct AE profile for our currently approved agents. If we look at this compared between the agents ribociclib and abemaciclib, we can see that there's a distinct spread and difference. So abemaciclib, the most common toxicity is diarrhea. This can happen in up to 80% of patients, but it's only a small percentage, 7% in the Monarchy study who experienced grade 3 diarrhea. On the flip side, the most common toxicity with ribociclib is neutropenia. We can see that about 60% of patients experienced any grade neutropenia, about 40% grade 3. Notably, that rate is lower than what we see in the metastatic setting in the Mona Lisa trials, because in Mona Lisa, they used 600 milligrams of ribociclib, and in Natalie, the dose used was 400 milligrams. So we see less grade 3 neutropenia. It's also important to note that the neutropenia seen with CDK4/6 inhibitors is asymptomatic. Patients do not get febrile neutropenia. They do not have a compromised immune system, but they can be quite neutropenic, which requires management. Other side effects that can be seen, both of these agents can cause mild to moderate fatigue, which is common in general in breast cancer survivorship populations. And both agents, but particularly ribociclib, is more associated with LFT abnormalities. And we can see close to 10% of patients may experience grade 3 LFT abnormalities. So because of the differences in the side effect profiles, the monitoring for patients who are receiving either abemaciclib or ribociclib is slightly different. For both of these agents, we do need to follow laboratory testing typically every 2 weeks for the first 8 weeks of treatment. We want to follow a CBC to make sure there's no neutropenia. We want to follow liver function tests to evaluate for those that small percentage of patients who might develop more significant LFT abnormalities. Now, importantly for ribociclib, there is a rare risk of QT prolongation. So patients need to have a baseline EKG before starting drug and a follow-up EKG after 2 weeks on therapy. So 2 EKGs to screen for QT prolongation. And then other toxicities, which are less common, but we always have to keep in mind, include ILD or pneumonitis. So patients who have persistent pulmonary symptoms may need to have that worked up. And there is a risk of thromboembolic disease with both of the drugs. For this reason, I personally would not be giving these with concurrent tamoxifen because that would be too much blood clot risk. Okay, so let's go back to our case. Remember, this was a patient with high-risk node-positive disease. She's completed all of her immediate therapy. She's on endocrine therapy, and she has been initiated on abemaciclib at the standard dose of 150 milligrams twice a day. So let's think about how we're going to manage this patient. First of all, how often should we follow up and monitor the patient? What factors and tests should we assess and monitor? Well, we know we need to follow the patient with labs every 2 weeks for the first 2 months of therapy, and then generally we move to laboratory testing every 3 months or so. Primarily, we're looking for neutropenia, we're looking for LFT abnormalities, but also these are moments where we can check in with the patient, particularly about diarrhea, because that is a common side effect with abemaciclib. And certainly we want to ask about it when we see the patient, but they should be telling us too about it if they're experiencing it. How can different members of the team communicate with and contribute to the monitoring and care of this patient to maximize treatment success? Here's where it really needs a multidisciplinary team. And I think for many of us, we are very fortunate to work with advanced practice providers such as nurse practitioners, oncology nurse navigators, as well as oncology pharmacists, all of whom can play a role in helping support patients receiving CDK4/6 inhibitors. I think it's very helpful when a pharmacist can do some teaching before the patient starts therapy to talk about how to take the medications, what side effects to look out for, and some ways to help manage them, as well as the importance of communication. And then I think it's also important to have APPs and ONNs checking in with patients, calling them, answering their calls, and making sure they feel really comfortable telling us about any side effects. I always tell my patients I'd much rather have them report everything that happens to them to me than have them come in a few weeks later and tell me everything was terrible without ever telling me about it. So I think the communication is super, super important. And then, we should tell the patients in advance about things they might experience so that they're prepared. And again, some of the more significant things to look out for, such as diarrhea, need to be talked about in advance so it doesn't come as a surprise to a patient. What if the patient starts therapy but doesn't refill the next prescription without a known reason or explanation? What if the patient is appearing to be non-adherent with therapy? And here's where, again, our pharmacist can be quite helpful in education, but also having the frequent contact with patients and checking in with them, making sure they are taking drug, and if not, exploring why and what's going on. Did they stop drug because they're having a side effect? If so, let's talk about it and let's talk about ways to manage it. And that hopefully will try to keep them on therapy and improve adherence. So you're about to enter an immersive AI-driven case simulation. Access the practice aids if you have not yet done so. Chat with the patient about their experience with adjuvant therapy, potential adverse events, and their monitoring plan. After you've completed all the objectives on the evaluator checklist, click on the next chapter to move on to the next segment. Okay, so let's return to our case. So remember, this is our postmenopausal patient with high-risk, node-positive, hormone receptor-positive, HER2 negative early breast cancer who was started on adjuvant abemaciclib 150 milligrams twice a day. She is already on an aromatase inhibitor. She has some mild arthralgias, as we might see. So since she started abemaciclib, she's had persistent and recurrent diarrhea after the first 2 cycles, and she's also had some mild fatigue. She took a short break from abemaciclib. We told her to hold drug, and the diarrhea got better, but she got worried about the implications because she remembered our previous conversations about the risk of recurrence and why we want her to be taking abemaciclib. So she started it up again at the same dose, 150 milligrams twice a day. And again, she's experiencing the persistent and recurrent diarrhea, which we would consider a grade 2 diarrhea. So given this, let's think about what we want to do with her. First, let's think about dose reductions with adjuvant CDK4/6 inhibitors. So for each drug, we have different dose levels. Abemaciclib, the starting dose is 150 milligrams twice a day. That's the same dose we use in the metastatic setting. There are 2 dose levels we can move to. 100 milligrams twice a day is the middle dose. 50 milligrams twice a day is the lowest dose. If that dose is not tolerated, then the patient has to stop abemaciclib. With ribociclib, we are already starting with an upfront dose reduction because we are using the 400 milligram dosing in the adjuvant setting, not the 600 milligram dosing that we use for metastatic disease. So if they're at 400 and they're having side effects, we can go down to 200 milligrams once a day. And if that's not tolerated, then we stop ribociclib. So let's think about how the dosing and the toxicities played out in the registration clinical trials. So first, let's think about monarchy. Now, this is a figure that's looking at dose reductions and dose holds in monarchy. And I think you can see very easily that this is all front-loaded. These toxicities emerged very soon into treatment, just in the first 3 months, and that overall, about 43% of patients required a dose reduction, the majority in the first 3 months of treatment. The major reasons for dose reduction included diarrhea, neutropenia, and fatigue. Overall, in monarchy, 30% of patients discontinued abemaciclib early, and about half of that, about 18%, of the discontinuations were due to side effects. But interestingly, in the trial, about half of the people who discontinued for side effects didn't actually use a dose reduction. They experienced the toxicity and then they stopped drug. And that's not what we want. We want patients to be using dose reduction. Part of why we want people to do this is we know it helps with side effects, but we also know that it's not going to impair any efficacy we get from the drug. This is a very important analysis that came out of monarchy, looking at efficacy and treatment duration by relative dose intensity. So patients were put into one of 3 categories: a lower dose intensity between 0 to 66%, a medium intensity 66 to 93%, and then a higher intensity 93% or more. And if we look on the left into this Kaplan-Meier curve, we can see that the outcomes in terms of 4-year IDFS are basically the same no matter which of those intensity groups you're in. This is suggesting to us that patients who have a dose reduction, who then may have lower dose intensity, are still getting just as much benefit from the drug. And so we want to use dose reductions because this allows patients to stay on therapy. This allows patients to get full benefit, and they're not going to lose benefit by reducing the dose if they are not able to tolerate the higher dose. I've been very interested in this idea of how to make this drug, how to make abemaciclib more tolerable for patients. And we at Dana-Farber ran the phase 2 TRADE study, which is a single-arm investigator-initiated phase 2 trial that's designed to look at an early dose escalation as a strategy to help improve the tolerability of adjuvant abemaciclib, help patients reach target dose, and help patients stay on therapy without discontinuation. We presented the data and showed that this was a positive trial. This was a successful intervention. The patients who used this adjuvant abemaciclib dose escalation led to a greater number of patients, about 71%, who were able to reach and maintain the target dose of 150 milligrams at 12 weeks compared to the historic control from monarchy. We did have 13% of patients were unable to maintain the target dose of 150 milligrams. 9% of patients were not able to reach 150 milligrams. And 6.7% of patients, only 6%, had to discontinue early. 3 of those patients were for toxicity, and that's quite a low number. So that means that close to 95% of patients were continuing therapy at 12 weeks. And you can see this in the swimmer's plot to the right, that except for the patients at the bottom with the stars next to them, all the other patients are still taking abemaciclib at 12 weeks. I think you can also see in some of the patients on the lower part of the swimmer's plot, they tried to escalate to 150 milligrams twice a day. They were unable to do that. They ended up at a lower dose, but they were still taking drug. And I think that's really important. They found the drug, that the dose that was right for them, that allowed them to stay on therapy, and they were able to continue without discontinuation. Now, similar data have been seen from Natalie. We know that 27% of patients had to have a ribociclib dose reduction, and that the majority of these dose reductions occurred early on in treatment within the first 3 months. And most of these dose reductions were due to side effects such as neutropenia or LFT abnormalities. A fairly similar number of patients discontinued ribociclib compared to monarchE with abemaciclib. And also similarly, a good number of patients who discontinued for toxicity did not have a prior dose reduction. So again, this not using the dose reductions appropriately as we would recommend. And similar also to monarchE, an analysis looking at outcomes based on whether a patient had dose reduction or not suggests that patients who did use a dose reduction, which is the green line, did not have any decrement in the benefit from ribociclib compared to patients who did not have a dose reduction, which is the pink line. Let's just dig in a little bit with some of the toxicity management. So I've mentioned a few times that diarrhea is one of the key toxicities with abemaciclib. First of all, we want to be proactive. We want to educate patients about what to expect, and we want to encourage good communication. They should have an over-the-counter antidiarrheal ready before they start therapy. We could talk about dietary changes to help reduce diarrhea. And again, I'm talking about communication and the possibility of dose reductions if there is any emergent toxicity. If patients begin having diarrhea, they should start their antidiarrheal. They should contact the office. If it has not improved, they should start holding abemaciclib, and if necessary, reduce the dose. And just as a reminder, if patients have first occurrence of grade 2 diarrhea, they hold drug, and if it improves, then they can resume without dose reduction. But if they have recurrence of grade 2 diarrhea, then they have to hold and then they dose reduce. And so I think this is going to happen very rapidly if the patient continues to experience diarrhea, but this allows them to get to the proper dose for them so they can tolerate the drug and stay on therapy. Also, just for hematologic toxicity, as I mentioned, we want to be monitoring for the development of neutropenia. If patients have grade 1 or 2 neutropenia, we don't do any dose modifications. At first occurrence of grade 3 neutropenia, we hold dose until it resolves, and then we can restart without dose reduction. If there is a recurrence of grade 3 or grade 4 neutropenia, then we hold until it resolves, and then we have a dose reduction. And then just a reminder that we really want to think about how to optimize adherence and persistence when we are using an adjuvant CDK4/6 inhibitor. There are obviously many factors that play into a patient's adherence to therapy. And this can include aspects related to the patient, him or herself, aspects related to the therapy itself, issues from the disease, the overarching healthcare system, and socioeconomic features. And so, there's a variety of measures that we can think about how to improve adherence. And this includes good education, clear instructions, education from our pharmacist, outreach to assess and manage side effects, and making sure patients know about what we will do if side effects emerge, for example, dose reduction. And then, patient-related interventions, including assessing patients' psychosocial needs, using whatever type of educational modality works best for them, whether that's a brochure or a video or a conversation. Okay, so let's come back to our case. Remember, this is our patient, Tina, who initiated abemaciclib at 150 milligrams twice a day. She experienced grade 2 diarrhea. She briefly held therapy. It got better. She resumed at the same dose, 150 milligrams, and the grade 2 diarrhea is back. So what should we recommend to her to manage her diarrhea? What should we do? I would think, first of all, we want to hold drug. Hold drug until the diarrhea resumes. And she's already done that once, so we know that that's a helpful maneuver. Now that this is the second occurrence of grade 2 diarrhea, it's time to reduce the dose. So instead of 150 milligrams twice a day, we'll bring her down to 100 milligrams twice a day. Hopefully that will help her. We do have an additional dose modification available if necessary, but hopefully with the single dose modification, she'll reach a steady state where she's able to tolerate the drug for the planned course. What about fatigue? That is a tricky side effect to manage in all of our breast cancer survivors. Certainly, fatigue related to CDK4/6 inhibitors does get better with dose reduction. So, doing a dose reduction for diarrhea will hopefully help the fatigue. But I think we'd all agree that fatigue is multifactorial, and there's a lot of things that can play into fatigue, including sleeping disturbance, hot flashes, night sweats, depression, other kind of psychosocial stressors. I think one strategy that I use personally with helping patients manage fatigue is, first of all, working on sleep quality. And we have a sleep specialist who I sometimes will refer to really help patients maximize the quality of sleep. And I think increasingly we as medical oncologists need to really lean into encouraging regular exercise for our patients. So what if the patient doesn't tolerate the drug despite dose reduction? So for example, if patients sometimes get LFT abnormality with ribociclib that does not get better with dose reduction, what if the patient continues to have diarrhea with abemaciclib? This is a good time where it's nice to have two drugs, because if they can't tolerate one, because the side effect profiles are non-overlapping necessarily, one could switch to the other and complete a course on the other medication as tolerated. And what if the patient or provider is reluctant to reduce the dose? Here's where I'm so grateful we have this data looking at outcomes based on dose intensity, because I think it's very helpful to share with the patient and provide reassurance that dose reduction is acceptable and is encouraged if necessary. And also share with our colleagues. I think we in oncology kind of get stuck on certain doses sometimes. And here's a situation where the pharmacokinetically, the lower dose is just as good. And so we should be using that if necessary, if the patient can't tolerate standard dosing. Thank you for participating in this AI-driven educational activity. I hope you have found it interesting and useful for your practice. If you haven't already, please also participate in part 1 of this educational curriculum.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/DTQ860.